Good morning, everybody. Welcome to the latest edition of Raising the Bar Live. My guest today is David Balat, a former healthcare executive, now healthcare expert, and I might add legislative wizard, who has brought us in Texas something called HB 2002. He was instrumental in the very broad effort to get that done. If you know, you know, and if you don't, and most people don't, we're going to talk a lot about that today. But first, I want to say welcome. Thank you for joining me today. And I want to talk a little bit about how you evolved from being a healthcare executive into reforming how healthcare gets paid for. I think it's a really interesting story.
I appreciate that. Thank you for having me. It's good to be here. I've been in healthcare ever since my first job, working in medical records as a 15-year-old. So it was always in the hospitals, and I love the hospitals. And I thought my direction was to go into medicine, and that it wasn't for me. But what I did love was patient care. And when I was going down the administrative route or the track for my career, I recognized an opportunity, along with getting some good advice from some of my mentors who were physicians, where I could create an environment for people who were highly trained to do the things that they were trained to do for the betterment of our patients. So that was my role. That was what I saw as my personal mission.
Mm-hmm.
One of the mentors I mentioned, he said something that was key in how I viewed the management and leadership of a hospital. He said, "David, nothing happens in a hospital except for at the tip of a doctor's pen." That really does radically change the way that you view how you do things. Because I'll tell you that most of my colleagues in hospital administration don't like doctors. They don't like dealing with them. And that was part of the push to employ them so that they could control the pen. They bought the pen, essentially.
Mm-hmm.
And it was a lot easier to move the pen in a way that benefited you if you could exercise that kind of influence and control, to be quite honest. My approach was vastly different and focused on partnership.
Can we talk for a second about what happens when either the hospital system or the insurer employs the physician?
Well, your motivations change. They'll say at the onset, "Well, we want you to practice, good medicine, independent thinking. You know, your medical decision making is yours. We're not going to do that." But the way that they structure their compensation or their bonuses, or let's look at those are the carrot options, but there's a stick as well. You'll get censured, you'll get pressure from your colleagues or from the leadership, and they'll just make your life difficult if you don't keep all of the referrals domestic. If you try to refer outside of the system, you will hear about it. If you try to, be maybe, and I've heard some of these stories. This isn't universal across the board, and I'm just giving you some anecdotes. Some doctors that maybe are a little more conservative than others, they'll say, "Well, that's not the standard of care."
Mm-hmm.
And they'll use that language to say, "You're not being more aggressive in referring to this doctor or that doctor, or getting this imaging or that imaging." It's expensive, but it's what's expensive to us is good revenue for the hospital.
I think people forget that. And I also want to say that hospitals are very important. People are alive because of hospitals. And we
Great.
just seem to have created this system that is so incredibly complex and no longer geared to the patient. And I want to give you a story about a referral. And it's my mother, so I can talk about her. But her primary care referred her to a cardiologist. He is owned by a local. I'm in San Antonio. His practice is owned by a local hospital system. And when I pulled the Quantros data on the provider, the quality score was 27 out of 100. And that wasn't okay with me. And she was afraid to buck the doctor. And it wasn't until there was a mishap that I could get her to agree to buck the doctor. And now she goes to a cardiologist that is not in that hospital system, but has a quality score of 99. And I think people don't realize that when physicians are owned by the hospital system, domestic referral means within the system. And domestic referral means imaging down the hall at the most expensive place to receive imaging, even though the machine is down the street, is exactly the same.
Yeah, I don't know how old your mother is, but we're really dealing with a lot of generational uh, conditioning.
Yep.
Some of the older folks like my parents, if, well, not so much my mother, but if your doctor tells you to
You're
do it,
going to do it.
you do it. Um, the younger generations are not so much like they're looking to research and look at Quantro scores or looking online to see what pricing may or may not be. They may not understand what they're looking at, but at least they're trying, which is a great sign for what it is that we're trying to accomplish.
I agree. And I think that is a perfect segue into our main point of discussion today, which is HB 2002, which I can't say enough how remarkable it is. And how, as a practitioner of, or an architect of building, of health plan building, how important that is to me when we're processing claims or we're getting claims processed. And I want to also spend a little bit of time talking about how we can educate providers on this, because we do need providers as partners in this. But let's talk about exactly what the bill is. And it is about 5 sentences. You want to share what that is, or would you like me to do it?
If you don't mind reading it, I need to get my glasses. So.
Okay, so this is the shortest bill I think I've ever seen.
Yeah.
An insurer shall credit toward an insured's deductible and annual maximum out-of-pocket expenses an amount the insured pays directly to any physician or healthcare provider for a medically necessary covered medical or healthcare service or supply if a claim for the service or supply is not submitted to the insurer and the amount paid by the insured to the physician or healthcare provider is less than the average discounted rate for the service or supply paid to an equivalently licensed or authorized preferred provider under the insured's preferred provider benefit plan. So that's one really long sentence. But what that means is go anywhere you want, pay cash, submit your claim, get reimbursed. Yeah. Now, the devil's in the details.
Right. And those details are still being worked out in the rules process.
Yes.
And we're still waiting for the outcome of that. But let's just use a real life example so that people who may not have, and usually if I look at language like that, I have to read it 3-4 times to really understand it. So especially with being read, it's hard to process, I'm sure, for people who are visual like myself. But let's paint a picture. I'm a patient and I have, let's just call it Blue Cross. And if I go to where my doctor tells me to go and I have an opportunity to I need a CAT scan of the abdomen, that the in-network rate with that hospital, let's just call it $1,200. The average in-network rate, let's just say it's $900, because that's what the language in the bill says. So if the average discounted rate for the service or supply in the region, let's just say that really is only $900, but it's $1,200 at this hospital because they're part of a system and they've negotiated bigger rates. But I'm able to get one for $250 cash. I can take that, I've paid it, I can take that receipt, I can submit it to my insurer, and it will now be applied to my deductible and maximum out of pocket.
Yep.
Many people would avoid going out of network because they're going to say, well, it doesn't really count. But insurance, well, the consumption of healthcare services by way of our insurance has changed. Deductibles, coinsurance, copay, maximum out of pocket have become extraordinarily high. And the most recent information I've seen from the insurance industry is that 80% of Americans never hit their deductible.
Mm-hmm. More than that, probably.
And maybe even more, which renders us cash patients. So now as cash patients, we have to look out for our own best self-interest. And with this law now, it can contribute to our deductible. I don't know why that seems like common sense, but now it's a matter of law here in the state of Texas. And I have to give credit To the authors in the House, it was Dr. Tom Oliverson and a gentleman by the name of For Price. And in the Senate, it was Kelly Hancock. Both Kelly Hancock and Dr. Tom Oliverson were also the architects of the the surprise billing law that we had here in Texas prior to the No Surprises Act.
And let's talk about that a little bit. I know New York has a law quite similar to ours, but ours was one that seemed to get the most attention, and they are remarkably similar, I understand. What that meant for patients, and again, how there was a lot of cross-pollination of people who were interested in this bill and getting this passed.
Right. It was very difficult to get across the line, as you can imagine.
Yep.
The insurance industry did not want to be a part of this at all, and they were also under a considerable amount of pressure. And kudos to the gentleman that I mentioned for not wavering and really holding the line, because they knew that this was about helping patients.
Mm-hmm. And we seem to have so I think Texans in general have a pretty independent streak, even those of us that got here as fast as we could and weren't born here. And we often like to do things our own way. And I think that allows us to do some things that other states don't have the luxury of doing. Can you talk a little bit about how this process is being worked out in rules and what some of the biggest speed bumps are? Because I think that while the bill is one sentence, the implementation of this is going to be fairly complicated on the operational side.
Right. Well, the biggest fight, if you'll notice in the language, I think a mistake that was made that other states will want to take notice of is that you'll see that it says, or it doesn't say that it will be applied. It says it'll be applied to your deductible and maximum out of pocket. The insurance companies are now saying, well, it'll be applied to your out of network deductible as opposed to your in network.
In network.
So I think in other iterations in other states that it should be specific, because the intent of the law was that it would be contributing to the in network deductible. But even though that was the intent, it wasn't in the language, and I think that there's just a big fight over that right now in the rules. The authors are continuing to fight. Many people think that once you have a bill signed by the governor that it's over. That's not the case at all. That's really when the fight starts. Because most people are backing off, they've declared victory. The team of lobbyists are their ears deep in the detail.
Mm-hmm. Well, we'll leave that story for another time. But I think it's like logistics, right? Armies travel on their bellies and governments run on their rules, right? And the big fights happen in the rules. How are we communicating this to doctors? Because when I talk to doctors, they're like, what?
Yes.
And not only that, then they don't know what to do with it, right? They're like, well, okay, great. What am I supposed to do with that?
Well, I'd love to share a story. I was having a discussion with a hospital that's part of a system in Northwest Texas. It's a secondary market, not a big town like Houston or Dallas, but they had called because they were running into a little bit of a problem and were trying to find some opportunities for overcoming the issue. They lost the contract for the school district. The school district didn't include them in the network, although they had been there for a long time. It went to the competing hospital across town. And I said, well, have you heard about HB 2002? And they said, no. What does that mean? I said, well, even though you may not be able to be in the network, you can still attract people by having a lower cost for services and then having them pay for those because they're essentially cash patients. And then taking those receipts and having them apply to the benefit deductible. They got so excited. They said, well, what's the opportunity? What can we do? I said, well, it's a school district. You've got a lot of females, of
kids,
childbirthing years. Why don't you establish a bundled price, a bundled affordable cash price for L&D? They said, we can do that. And so
L&D is labor and delivery.
LS, my apologies. We talk in acronyms in
We
healthcare.
do.
So labor and delivery. So a normal birth, no complications, no surgery. They were talking between 4 and 5 thousand, complete all-in price. Now, that's very different from their other prices. But if you can establish that as a single use agreement, as a cash price for that family, have them pay it up front, then you know you're going to have droves of people coming to your hospital, and then they'll be applying that to their deductible with the system over there.
And I would point out that, let's say it's $5,000 for almost every plan. That is, maybe the deductible is low, 1,500 or 2,000, maybe 2,500 for a school district, but their max out of pockets are $7,000, $8,000. So they're going to be paying that $7,000 or $8,000. Typical delivery rate on a PPO network is probably in the neighborhood of $20,000, give or take a little bit. So this is about a 75% discount. And if you're not hitting the annual out-of-pocket max, if you know you're going to spend $5,000, better budgeting. And I think most families would like to pay $3,000 less for a baby delivery.
Well, and in some of those markets where you don't have a lot of competition, which is really some of the biggest issues that we have
Yep.
in healthcare. We're working so hard on transparency, but transparency without competition just lets you know how bad you're getting screwed most of the time. So it's really, and I've got to credit that to Chairman James Frank, who said that in committee. He was a little bit more colorful than I was, but it's absolutely true. And so laws like this don't really add to our transparency efforts, but it certainly may add to our efforts to make things more competitive. Because in the example that I just gave you, that hospital is very incentivized to create a bundled price that is affordable and will allow them to recruit or to market to a population of people. Now, you still make a market, you still make a margin, you still make enough to cover your cost and keep your doors open.
And I want to throw something else in here. I think everybody, well, many people who don't live in our world think, the insurance will pay for it. And the insurance might pay for it, but it probably takes 60 or 90 or 120 days to get paid. And then there's clawbacks. And then there's all this aggravation over here. And then you have people calling to find out where they're getting, where's our reimbursement? Where's our reimbursement? Where's our reimbursement? When you have a cash payment price, you're paying that up front. Yes.
Yes.
But the hospital doesn't have a revenue cycle problem. And all of that cost to collect goes away.
Yes. Yeah. The infrastructure that's in place necessary to collect the money for the services you've already rendered is exorbitant. It is so high. Insurance has contributed to the inflation of our cost structure significantly, and I'm sure it does in other ways as well, but just that alone. You look at a primary care, one of the reasons why it's so difficult to be a primary care doctor in this country, I think Milliman came out, it's 40% of the overhead on average is dedicated to verifiers, people who are authorizing, systems that will allow you to submit claims, the cost for a clearinghouse, collection agencies, all of these things. Again, cost associated with collecting the money that you've been promised in a contract.
40%.
For the services you've already rendered, and hopefully you'll get it in 30 days.
If you're lucky.
If you're lucky. And then you see what's happening with Change Healthcare, and they're, United Healthcare is extorting physicians at this point, which makes you wonder how much of this was accidental or nefarious or maybe even contrived.
So you have you believe that UHC will start buying hospital systems?
That's a prediction I just recently posted on LinkedIn. It makes sense to me.
Me too.
If I were to put myself in their shoes strategically, you look at what they're doing, and they're buying pockets of primary care physicians in concentration. And why would I do that? Well, I would want to control the referral. Primary care physicians, although many of them don't recognize it, that is the most powerful position, because A surgeon doesn't get a case if it's not referred to them by someone.
Primary.
And so if you've got a steady flow of referrals based on your patient base, you're able to direct it. And that direction is powerful in healthcare. And so, like I mentioned with the hospitals wanting to employ physicians, that's why. Um, but now United and I think they employ close to 10% of the physicians in this country.
Largest employer of private physicians in the United States.
Largest employer, which is a scary thing to say out loud. But if I've got that kind of influence and control over primary care in concentrated markets, I don't have to spend any money on the specialist. I don't have to pay for the expensive specialist. I can keep a hospital relatively full on just the primary care, and I can influence and control the specialists, not necessarily because I employ them, but because I control their referrals.
Yes. And I think that leads to not necessarily the best physicians, but the physician down the street. And I'm going to go back and use my mother as another example. My mother is older, obviously. I'm not a spring chicken either. And she occasionally meets with the PA if the physician is not available. The PA was just let go because from the doctor's mouth, she was not seeing enough patients in a day.
I've got feelings about that.
Well,
but that's the world. But that's the world we live in, Allison.
That is the world we live in.
I think the average visit time is 5 to 7 minutes in the current model that we have, where you take insurance. They're spending that much time or more on the documentation after the fact. And that's why we see signs on the door that say no more than 2 diagnoses at a time. You have to come in for another visit if you have more than 2.
And that's not
where
good
we want to be.
Health.
Yeah, that's not really healthcare. It's a sick variation on sick care system, because everything is based on disease and a diagnosis. We don't have the time to educate people. We don't have the time to focus on where they want to be with their health in a year, 2 years, 5 years, 10 years.
Or focus on it. Even ask the question, why are you here? What is the problem? Let's address this problem and we will farm everything else out.
Yeah, my position has always been is that healthcare is about medical professional and patient. And the problems that we can see visibly with our eyes and that we can understand theoretically is that we've got so many third parties, so many middlemen that are injecting themselves between those 2 stakeholders, insurance being one. But the most clear visual representation is, I'm sure everybody here has had an experience where they go to see the doctor, and whereas in the past they used to check your throat, put your hand on the belly and all those, and now they're in a corner tapping on a key, entering data into a billing system. And I'm not saying this in a mean-spirited way. I really do feel bad for these people who have been trained to take care of people, because now they've been relegated to being very highly paid data entry clerks. That's what we don't need.
No, we need, primary care physicians are retiring at an alarming rate. We don't have enough to replace them. We don't actually have enough doctors to go around. And I think the more we can help them be independent, the better off we are. Agreed. As a society, never mind health insurance, but as a society, when people can get care. We have direct primary care at one of several of our clients, but at one of our clients in particular, they're in another state and they have a different provider. And for the folks in San Antonio, we have an on-site clinic, but they have their own provider. They all go to the same group. And the senior HR person at that location was at an executive level meeting. We do one a year. And she said, "Oh my gosh, they asked me how I was sleeping." She said, "It was fantastic." And they just went through, she was having some health issues, minor health issues, things that any of us might have, but they literally went through, okay, the sleeping and the diet and the movement during the day and the exercise and where did she want to go and what was her lifestyle. She said, "I haven't had that in my adult life." And she's like 40.
Yeah.
And it is remarkable what allowing physicians to be physicians can do for a patient.
Yeah. Well, and for the same code that many doctors document, they're saying that they're receiving that information because of those forms that you're filling out.
But they're not.
The receipt of those forms helps to augment the escalation or the increase of the code that they're billing for. But do they often get the chance to ask those questions? It's challenging. They simply do not have the time.
Correct. And I think that's important to recognize. This is a time issue. It's not a I don't want to take care of you issue. So I have a panel of 3,000 patients and I have to get through my day.
And with many of them being employed, it's I'm going to get in trouble, or I'm not going to make my bonus, and it's transitioned into something else. The incentives and the motivations have changed.
And let's circle back to providers now and talk about how we can help them understand what this is, communicate what it is, understand what it is, and help them utilize it. Because I think it can be a wonderful tool to keep physicians independent. And most of the physicians I know would like to be independent or are on their way to becoming independent or already are.
Right. It's daunting. It's because not only is there the challenge of opening up your own business and starting your own practice, it's the fact that the hospital, if you leave, will, and this is a story I've heard, they will try to run your business into the ground. They will drive you out of business because you've left them and you were not loyal to them, and so they're going to harm you and they're going to use their resources to do so. That's not far-fetched. I've heard it more times than I'd like to count, but there are a lot of fears, and getting an insurance contract is another. Across commonly with independent practitioners will say, here's a contract. There's no negotiation. Here's a contract. It's below Medicare. Take it or leave it.
Yep. Yeah. And that's not a way to run a business.
It's not. And I'll tell you, Cigna once told me when it was in a hospital, and our managed care people brought it to me because they just weren't getting anywhere. And we walked through each of the services that we're offering, and I said, look, well, here's one that we do a good bit of. And she said, well, we can offer you X. And I said, well, X just happens to be below our cost. And she said, well, you'll make it up in volume. What do you say to that? That new math doesn't work.
No, that math does not work. So let's talk a little bit about how you think the rules process will shake out. Will we get these cash pay services applied to an in-network deductible, or will they only be applied to an out-of-network deductible? What other implementation hurdles do you see?
I should have an update for you soon. I know that the authors are going to bat on this, and they're working hard to make the rules consistent with the intent. So I think that we'll get there, but you never know. But we'll see. If it has to come back in the next session where they'll amend the law, they'll do that. But that's where we are. I think that this is just, you always learn. This was challenging to get across the finish line. I'm glad we did, but I think other states should be able to learn from this as well.
Have you been hearing from other states, about a desire to do this? We haven't not done a lot with prescription drugs, but other states have. So I know there's interest in helping consumers. Is this something that you think will spread fairly quickly? And what do you think that will do to managed care as a whole?
No, I think it's good. Managed care, they tend to roll with the punches. They don't like it. If we can they fight like hell to stop the effort in the process. They use all their dirty tricks to get things stopped. They've done that to me numerous times on a number of bills, and they don't play nicely. But when they lose, there's not really an option. The biggest hurdle outside of the issue we're having in the rules right now is making people aware. And I'm thankful that you're doing that here through this medium. That's one of the reasons why I've gone back into consulting as well, is because Of the 18 bills that I was a part of getting passed into law during my 4.5 years in Austin, I'm seeing a lot of them just sitting on a shelf, not really being made use of. And so there's opportunity for the things for people watching this that they could employ as part of their practice, to work with providers, to educate patients, to help benefit their employer clients.
So, what would be your top advice for a provider looking to implement this as a solution or as a different tool?
I think, well, if you look at the law itself, the insurers must provide a web portal or something on their website. I think one of the things, as soon as the rules are done, is that we start collecting what those websites will be as a provider, so that you can say, here is a bundled price. This is something else that is important, and this is the direction that I think that we should all move in. And I think a lot of people watching would believe this as well. Is that stop with this unbundling, bundle the prices, have them at rates that you can understand. Do complications and weird things happen? Yes, all the time, but you can accommodate those on the back end, and have line item pricing for those if that's appropriate. But have the pricing available to people, and then once you have that there, make the arrangements for them to pay, and then give them the tools to be able to submit that to the insurance company so it will apply to their deductibles. And then there's the other opportunities that I was sharing with hospitals that are maybe trying to be more competitive. If they're in a highly competitive market where, well, between them and one other, it's not a competitive market, but they're in competition with another hospital system. But they can truly make it a competitive market for patients if they want to do the things that we're talking about.
Can you talk a little bit about, so we have a couple of comments here about competition driving everything and about charting being a huge problem, not just in the room, but out of the room. And one of them is from our friend Nancy Giacalone, who was talking this morning about how she tried to pay her provider and she cannot. Might be a change health issue, but I think it's not an uncommon problem. If you don't work in the insurance company, a provider may not know how to accept money from you. How do you feel?
I don't necessarily believe that personally. I know that many places have a policy internally to just take the insurance. If you know they have insurance, take the insurance. They'll say, I've heard many times where they tell patients, well, it's illegal for us to take cash if you have insurance. Well,
and that's not true.
That's not even a little bit true, and frankly, it's just a bad lie. So there's that. There's also they'll say, well, it's our internal policy that if you have insurance, we have to take your insurance. I say, well, it's nice to have policies, but this is your life, not theirs.
Correct.
I always tell people that if you are inclined to pay cash, ask the cash price before you even present insurance. It eliminates a lot of these problems, because some of them will just be dogmatic. And then again, you have to remember, people at the front desk, they're just following rules.
And they're incredibly overworked and incredibly underpaid.
Both are true.
And I think we need to give front desk folks some slack. I had an interesting experience at my own doctor, and I called and I used to have Aetna, and I do not anymore, and I not for any nefarious reason, and I'm a cash pay patient now with some other things on the back end. And I called and said, and they said, oh, are you still with Aetna? I said, no, I'm a cash pay patient. And they're like, you don't have insurance? I said, well, I have a high deductible plan with no network. I'm a cash pay patient. And the very lovely woman on the front desk said, could you hold, please? And I said, And she came back a few minutes later and she said, apparently the visit price is $85 and you'll have to pay that when you check in.
Yeah.
Okay. Are you sure? Oh, okay. I get there. I pay my $85. I go see the doctor. I leave, and another woman at another counter says, oh, you have to check out and you have to pay your copay. I said, no, I already paid for my visit. What do you mean you already paid for your visit? This is a small independent firm. I mean, it's two doctors, right?
Yeah.
And they had to go have a consultation. They were very nice. but
Yeah.
they had to go have a consultation about this crazy woman who paid cash. We don't see this. Why are you doing that? Well, you just got paid and I got seen and we're good now.
Yeah. Imagine that.
Imagine that.
Paying for something and getting the service in return. That's so uncommon.
Yes, and you just pay and they take credit cards apparently,
They
and
do.
off you go. And,
That's
and
it's a
that's
lot more useful than an insurance card.
it is a lot more useful.
Yeah.
Cash is great, right? Credit cards are great. But I noticed I have I met with the CEO and the executive team of a local orthopedic facility, and they're trying to figure out how to take direct payments like direct contracting from employers, and they are making a mighty effort to do so, but they are having some challenges. And her staff kept telling her that she we're in Texas. We're in this part of Texas. How many insurance plans could there be? A couple of hundred? 3,000.
So many.
And they all have a different fax number, they all have a different telephone number, they all have a different mailing address. That's why 40% of the cost is in administrative and collection. And if they send it to the wrong place, it entirely goes off the rails.
That's right.
So they're working mightily to get to a cash pay environment. It's hard.
It's hard, but it's not impossible. There's really, I right now, one of my consulting clients, it's a hospital system. It's a smaller one, but they currently have 4 hospitals in Texas,
Mhm.
Dallas, Houston, and then West Texas. And I've known the owner for a long time, and I've been telling him about the things that I think would be good, and I think that they should consider. And in the 6 years I've been saying that to him, something happened last year, and I love when that light goes off in their eyes. He's like, I get it now. And so he's approved a project going forward where we're looking at developing direct to employer bundled cash prices for everything in the hospital.
Wonderful. That is so wonderful. People have no idea how good that is for them. People think, oh, they're trying to crap out. My employer is trying to crap out. I can tell you from experience that isn't the case.
No, not at all. It's good. And where benefit advisors and brokers come into play is you can add that to an existing benefit structure.
Yes, you can.
And because the rates might be between 150 and 180, you establish a zero deductible, zero co-insurance, zero maximum out of pocket for your patient if they go to those facilities, because
Yes.
the savings are extraordinary, especially if you're self-funded.
They absolutely are. I'm going to give you an example of that. We have a client that had a back surgery at a local facility here, and the bill charges were $80,000.
That's not uncommon.
Not uncommon. PPO price for that was about $36,000. The reference-based price at 150% of Medicare was $10,527, which seems reasonable to me. And we changed some arrangements within the contract. And the next year, there was a direct contract available for the same service, and the direct contract bundled price was $11,500. I would pay that all day.
Yeah.
And most employers would. And then they waive the deductible and the out-of-pocket, 000. And it's a win for an employee, and it is a win for an employer in how they engage with their employees.
Yes. Yeah.
And
That's what, 14%?
Mhm.
What the charge is?
Mhm. Yes, and I think that's fairly typical.
Yeah, I think that's right.
Medicare will shake out at 10 to 12, and 150 is 14, 15%. That's what you should be paying for services, and pay them quick. Pay them quickly and fairly, and move right along. And then healthcare isn't so expensive.
Well, it's what you have to pay them quickly in order to comply with the laws as well.
Correct.
Because when you have discounts that are that dramatic, you have to be able to extend that discount to everybody else.
Mm-hmm.
But typically, if you have a prompt pay component to it, you're using their bureaucracies against them.
Yes. And I think that's important too. I mean, hospital administrators, it is important that hospitals grow and be profitable and deliver the care that people need, as much care as people need.
Yeah.
And I don't think hospitals can survive on Medicare. It wasn't designed for hospitals to survive on.
Depends. It really depends. I think what's important is that when we talk about hospitals, is that we don't lump them into one bucket. Hospitals can be very different. You've got a rural community hospital that has 15 to 20 beds, and then you've got academic medical center.
Mm-hmm.
Both are
Very
hospitals.
different.
They're both acute care hospitals licensed under the state of Texas. They might have Joint Commission or CIHQ. What matters is we understand when we talk about hospitals. Yeah, academic medical centers, no way. They're not. Medicare is not covering their costs. Smaller hospital, yeah, maybe. Medicaid isn't, because Medicaid, I think, is 67% of Medicare here in Texas.
Yes.
So you might be able to get to break even with the disproportionate share money that comes from the state and the federal government and the uncompensated care monies. But for the payment that you're receiving, you're not covering your costs. Medicare, and I think you could look on Sage Transparency, which is a website that will tell you, it pulls the NASHB data to tell you whether Medicare is at break even or not, or if they're making a little bit of a margin.
Can you tell everybody what the NASHB data is?
It was developed by a good friend of mine, Marilyn Bartlett. I love Marilyn. She's the only person I have publicly referred to as my healthcare hero. She was the one.
She is.
That revolutionized the healthcare system in Montana, in the state of Montana,
Mm-hmm.
for the state. And she was able to get the hospitals to reduce their prices and save the state multiple millions of dollars. So she then went on to NASHB, and she basically went to the Medicare cost reports and was able to develop a tool that would let you know, based on the hospital's own data, what their break even is, what their costs were, and where does Medicare fall in line with that.
Do you feel, I think that more use of that data would produce more effective health insurance for people. Do you see that happening as time goes on? Or is there simply too much pushback from the big carriers in order to access that data?
Well, it's publicly available.
Yes, but publicly available and usable are two very different.
True. But if you go to use some of those tools like I just mentioned, you can see what a break even is for the hospital and whether they're making money on Medicare or not. It's not going to help you win an argument, but it's a nice tool to have in your tool belt.
Yes. And can you talk a little bit about, well, tell us what you think about how employers should manage their health insurance budgets.
Well, I think Johnson & Johnson lawsuit has taught us that they need to be more involved in those decisions and be more involved with the team that they have around them to ask hard questions. They've taken a back seat to a car that they own for a very long time, and they've got to get in the driver's seat and be the fiduciary that the law requires them to be if they're going to be self-funded.
I feel like the CAA, the Consolidated Appropriations Act of 2021, was a huge gift to employers. I know many employers do not feel that was a huge gift, but I think it was. I think it allows them to perform their fiduciary duties with a big stick behind them. What do you feel, if anything, is missing from that?
Well, I think it's the same thing that I mentioned with HB 2002. It's the fact that they don't know about it, and they don't know what it means to them and what they can and cannot do under the law. Because, look, you and I and probably most of the people listening to this understand healthcare.
Mm-hmm.
We know what questions to ask. The people who are employers that are offering benefits to their employees, they didn't get into business to understand healthcare or healthcare benefits. It's not an interest in theirs. They hired people to do it, but mainly it's going to be your HR person or your CFO. They also are not trained in this. They don't know what questions to ask. They don't know what they don't know. So that's why it's so critical for the advisor broker with the proper accountability that's come under the CAA. to function as their Sherpa, as their
Guide.
person that's going to help them, their guide, to ask the right questions. But that's been a challenge too that is slowly turning around.
How do you feel that we can best speed that up? I mean, I'm one person and I'm fairly loud, but I am one person. We have a few people listening to us today who are equally as loud as I am, and we all bring our own perspective.
Sure.
But how do you recruit more of us? Is that why you're a little bit more involved with NABIP and some of the more independent associations?
I am. Well, it's important. The folks that do the things that you all do are, I've said, employers and their advisors, their brokers, are the key to fixing healthcare. We do not want the federal government to do it because they're really good and really consistent at screwing things up. So we don't want to put it back in their hands. And I'm very frustrated with employers here recently saying Congress needs to fix healthcare. No, they need to fix healthcare. And they need to get serious about it and stop complaining. Because look, if you have the ability to be brave and do some unique things, then just do it. But the challenge in corporate America is that there's a fear of trying something unique because it puts you in the crosshairs. Whereas if you use Blue Cross or Cigna or United, you can say, well, I hired the best.
Mm-hmm. It's like
you're then able to point that finger away from you instead of,
yep.
Well, we tried and it didn't work and it failed. So that's a scary proposition because people don't want to lose their jobs.
No, and I can understand that. It's like the old saying, nobody ever got fired for hiring IBM.
That's exactly right.
Until somebody did.
Yeah, until somebody did. And I was, and you know what? I was taught that at a very young age. As a young administrator, I was, trying to try things that were outside of the norm. And I was always pulled aside and counseled and said, David, I know you want to try this, do this, but just understand that these are the potential ramifications.
How are you talking to more people? How can we help you talk about this to more people?
I'm going on Raising the Bar Live.
Okay, but we're still very. We got to get you a few other.
No, I'm talking to as many people as I can possibly talk to. I'm also part of a nonprofit organization where we're trying to bring healthcare to people that are below or just above the federal poverty limit, bringing them direct primary care. So Direct Care Connect is the organization. And we're looking to raise money so that we can find DPC doctors in local areas and then sponsor scholarships for membership into those DPC practices.
So never allowing a doctor to never enter a hospital system is what I hear.
And patient. Because many of those patients will just end up in the ER because they can't get in. If you're a Medicaid patient or you're uncompensated or uncovered, you don't have insurance at all, then where do you go? You go to the ER.
The ER.
Yeah. Is the ER a good place to get health care? Absolutely not. Chances of getting sicker are probably considerably higher. So we need to get folks that are most vulnerable to have a relationship with their primary care physician.
We will post a link in the chat when we're finished to that site so people can donate and learn a little bit more about it, and we'll get that out as well and share that. I think the importance of basic healthcare cannot be underestimated. However, I also agree with you that federal healthcare is probably not the way to go either.
Well, there's already a track record. It's not theoretical. We know what will happen. We can look at the VA. That's the best example.
So I think that Tiffany has dropped. I'm not sure if she's dropped the link. I can't quite see that, but she has dropped.
I think that's the name of the organization.
Yep, Direct Care Connect. I think it's remarkable. Will you be spreading that out all over Texas? Where are you starting? Up in the north part of the state?
We're starting in a little community called Forest Hill.
Mm-hmm.
It's just outside of Fort Worth, and we just met with the mayor and city manager, and they are now a partner, and they couldn't be more excited. Our first event will be a health fair on August 10th, and there's the website now,
Yep.
directcareconnect.org. And so we'll be having a health fair, and we'll be seeing patients and adults and children on August 10th at their convention center there in the city of Forest Hill.
We might need to take a road trip for that one.
All right. Would love
So,
to have you. We need all the volunteers we can get.
yep. And I will leave it there at not. We'll leave it there today. So make sure to check out Direct Care Connect. If you have any questions about House Bill 2002, reach out to me, reach out to David. If you are a provider, we would love to help you. David particularly would love to help you. And if you are an employer or a patient, let us know how we can help you sort through that. And we'll be looking for an update once it gets out of the Rules Committee, hopefully in one piece. So thank you for joining me today.
Thank you.